So this is the 2026 update for infectious disease and some antibiotic review. Um, the last version was very different than this. Had some good stuff in it, but stuff that I think is less applicable to entry into practice. So here we go. All right. Mark Potter calls you. I'd like you to call in his antibiotic because his dentist has told him that he should have that prior to his teeth cleaning because he's had a total knee replacement. This is a controversial issue. A lot of orthopedic surgeons still do recommend that you do this, but the American Dental Association and the American Association of Orthopedic Surgeons says that it's no longer necessary. The problem, of course, is that you want to do what's the usual and customary thing in your region, and so you do oftentimes end up having to do that. The evidence seems to be that there's no increased risk of orthopedic hardware infection, but because of the theoretical risk, a lot of the orthopedic surgeons still do recommend it. So basically, it's amoxicillin 2 grams orally, and if the patient is allergic to penicillin but doesn't have a type 1 reaction, you could use cephalexin. That's also 2 grams orally, and there's other alternatives, but those get to be much more complicated, and you'll have to look those up. So basically, you got to kind of know what's the regional and surgeon preference, and then kind of decide yourself whether you're going to do it or not. So Millie Lynch is 56 years old. She calls you up and says, yeah, I got my usual UTI. It's burning. I'm going to the bathroom a lot. I'm having urgency. You tell her that she should swing by a local walk-in and drop off a urine just at the lab. And the dip shows positive leuks, positive bacteria, and negative nitrites. Now, usually with an infection, you'll have leukocytes, bacteria, and you will have positive nitrites. But not everybody that gets a UTI has positive nitrites. If you have a gram-positive organism, they do not convert nitrates to nitrites. That's the big thing. Most gram-negatives do, and of course, most UTIs are likely to be gram-negative. But in the very young and the very old, it is more likely to be gram-positive. The other thing that can happen is sometimes, especially women are peeing so often that they don't really have time for the bacteria to convert the nitrates to nitrites, so they will be negative nitrites. So if the nitrates are converted to nitrites and the nitrites are positive, that's very helpful. It's not exactly pathognomonic of a UTI, but it is highly suspicious. If they're negative, it doesn't necessarily mean. What could you do? Usual treatment would be Bactrim DS 1-PO BID for 3 days. That's the Sanford guide, as well as I think UpToDate, and most others say that. Nitrofurantoin, the monohydrate, which is the macrobid, is twice a day for 5 days medicine. It's on the Beers list, but only because they are concerned that the very elderly will not concentrate it enough in their urine. So it's not like it's dangerous in the elderly, it's just not as effective. Fosfomycin is a medicine that's a single dose. Sometimes we use that if we think compliance is going to be an issue. We use it a lot in college students. We've kind of moved away from Cipro because it's black boxed because of the tendon injuries. But if you really need to use it, I think it's reasonable to do that as well. Paisley. So Paisley is 2 weeks old. Mom brings her in and feels she has conjunctivitis. 2 weeks old is really too young to be having a bacterial conjunctivitis. So usually it's just a plugged tear duct. You look carefully, and the eye itself is not usually red. The conjunctiva is not usually red. There may be a little bit of a blepharitis, but it's going to be very unusual. And unfortunately, the thing that is most likely to cause a 2-week-old to have conjunctivitis would be chlamydia. We have moved away from using the iloticin or erythromycin in the eyes when babies are born. A fair number of moms and dads do decline that because they feel it's unnecessary, and it probably is in the majority of cases. But it does raise the specter that someone might have a chlamydial conjunctivitis a bit more often. So older kids that have conjunctivitis, it's definitely Polytrim is a common treatment, but it's not approved in under 2 months, and that's really the reason, is that it's very unusual to have a bacterial conjunctivitis in that age. In general, you're going to use ointment in kids. Drops are like rodeo, trying to get drops into a kid, even though parents are like, I just want to put the drops in. The reality is once they try to do it, it's very hard. If you do drops, you have the kid lay on their back with their eyes closed, drop it in the inner canthus, and then have them open their eye. So it's possible to do drops, but ointment is much better. With ointment, you have them close their eyes, put a quarter to half an inch on your finger. You've washed your hands very carefully, of course, and then just smear it right across the outside lashes, and the lashes will actually put it into the inside portion of the eye. So, common bugs for conjunctivitis, strep pneumo, H. flu, and Staph aureus. And in fact, we're seeing it less likely now as vaccines have decreased the number of strep pneumo strains as well as H. flu. And Staph aureus is in the environment, of course, but not that common in the eyes. So we don't see conjunctivitis anywhere near as often as we used to. Same things with otitis media. Many of the otitis media were related to strep pneumo and H. flu. So it's much less common than it used to be, but does still happen. So again, just reminding you that neonates are probably not going to get conjunctivitis. Infants and toddlers, H. flu, strep, BCAT is another possibility, and so that would be something that you would usually use Polytrim for. All right, Barry Tibbs, 60-year-old man, comes in for belly pain. He's got a 2+ pain in his left lower quadrant, doesn't have any peritoneal signs, no rebound, no Rovsings, no psoas. Rovsings, of course, is pain in the right lower quadrant when you palpate the left lower quadrant. Psoas sign is when you put your hand on their knee and tell them to pull up, and the psoas muscle, if it's irritated, will give them pain, usually in that right lower quadrant. Barry says, hey, Jeff gave me antibiotics for this last time. So what are you thinking? Well, maybe we're thinking that he had diverticulitis. You don't always need to do a white blood count and a CAT scan, but if you have any doubts, you probably do want to do that. Unfortunately, in the office, to get a CAT scan, we often have to get prior authorization and pre-approval, and it can be a few days. So if he truly needs a CAT scan, unfortunately, he's probably going to need to go to the ER. And generally, again, if you've got somebody that's older or a lot of comorbidities, you're probably going to do a blood count and maybe a CT scan. Drug choices, amoxiclav or Augmentin is now first line, usually the 875/125. If you need to or want to, you can use Bactrim and Flagyl, or Cipro and Flagyl, or levofloxacin and Flagyl. It's 2-drug therapy, a little more likely to have side effects. And moxifloxacin can also be used alone, although it's a little bit more expensive, so it usually is third line. Diverticulitis can happen on the right side. Usually about 85% of diverticuli are on the left side, 15% can be on the right side. But again, whenever you have right-sided, you're worried about appendicitis. In a female, of course, you've got all the GYN possibilities. But especially if you've got somebody and they had a lot of diverticuli on their last colonoscopy a year or two ago, and they've had it before, and they've had a CAT scan and it's been confirmed, most people will go ahead and treat them with antibiotics if they need them. Remembering, of course, that there is generally a feeling now that we probably can try to avoid antibiotics if it's a mild case. Now, most of these people, if they've shown up or they've had problems, most people are going to treat them. But if you're in the office and you say, hey, the next time you get diverticulitis, try having a clear liquid diet for a few days, try taking it easy, low roughage, low fiber, and see if it gets better on its own. And then if it doesn't, then call me. All right. Leslie Price is non-gendered, and Z says that Zai has been having infections in the armpits for several years and now has another one. So this is most likely hidradenitis suppurativa. It's something that you can use topical clindamycin for. You can use an oral tetracycline drug like doxycycline. As far as prevention, spironolactone and oral contraceptives can be helpful. Metformin can also be helpful. There is definitely a role for monoclonal antibodies as they tend to really decrease the incidence. Usually those are managed by dermatology though, and they will put them on longer term. So, Franny Coulter. So Francis has been having sinus congestion for 9 days. He's 51 years old. Blowing green stuff out of his nose. He thinks he has a little bit of a low-grade fever. 2 months ago, he had a sinus infection that was treated with amoxicillin. So there's a lot of questions in here. Some people wait till patients have had symptoms for 10 days. Other guidelines say 7 days. Other guidelines say 7 days. And then if the patient's getting worse, go ahead and treat them. So it's a very much of a judgment call. There's guidelines that can tell you almost whatever you want to hear. And I think that anybody that's following guidelines strictly is probably not necessarily doing what's best for their patients. So here we go. Let's see. So acute bacterial rhinosinusitis, the Infectious Disease Society of America says 10 days. At the date says 7 days, unless there's double sickening or double worsening. Dynamedex says 10 days or 5 days if they're feeling worse at the end of the 5 days. So Amox is okay. The ENTs don't think Amox is enough, but the patients that they see are obviously the more resistant ones. Amoxiclav would be the next step. And if they're allergic to penicillin, you could use Doxy, you could use Levo, you could use Moxy. They don't recommend macrolides. Macrolides are not strong enough usually, although a lot of patients will ask for a Z-Pak. They've had a good luck with a Z-Pak. And so many of us will go ahead and do that if the patient is really wanting us to, but there's probably not terribly good evidence for that. Bactrim is an old-fashioned. We used to leave people on it for at least 2 weeks. Bactrim is a bacteriostatic antibiotic, not bactericidal, so it's going to work much more gradually. But I have had good luck if I keep people on long enough. The second and third generation cephalosporins aren't really recommended either, although many of us will go to Ceftonir, which is the third generation cephalosporin, especially if we really are trying to avoid levofloxacin or some of the other strong ones. The number needed to harm is only 8, so you are probably better off not to treat if you can avoid it. The number needed to treat is somewhere between 13 and 18. So there are people that really do get better on antibiotics, but the potential risk of harming somebody is as much or worse. So definitely be careful with antibiotics for sinusitis. Acute bacterial rhinosinusitis, 35% are strep pneumo, 30% are H flu. Again, as kids age, we're going to see less and less. Moraxella catarrhalis is 15%. Staph aureus is 10%, and strep pyogenes, which is group A beta hemolytic strep, the same one that causes strep throat, is about 5%. And again, you can definitely go with Doxy if somebody is penicillin allergic. Fluoroquinolones are often used by the ENTs, and they'll often add steroids on them if they're very severe. So Bart. So Bart is 25 years old. He's a Jehovah's Witness. He has a really bad tooth. Dennis told him to come see you, and she would see him next week. So Jehovah's Witnesses do not refuse medical care. The only thing they won't take is blood products, but everything else they're fine with. Christian Scientists are supposed to refuse all medical care, but many of them, if they get extremely sick will seek out traditional health care, and they're not usually shunned if they do. Um, Number three is a specific tooth. I'll show you in a minute on a picture where it is. If you look it up in Sanford for an odontogenic infection, they suggest amoxiclav. Many of us will still use plain amox. Up to date says there's too much resistance, but many of us have pretty good luck with it, and it's inexpensive and has much less for C. diff and other side effects than the amoxiclav. Clindamycin has a lot of C. diff, and so clindamycin is one of the ones that the dentists really like. But they'll often show up in your office 2 or 3 weeks later with very foul-smelling diarrhea and difficulty controlling their stools. Some people use Doxy for odontogenic infections. Not great results, but I have seen people get better. Pain control, be very aggressive. Max dose NSAIDs, max dose acetaminophen. If it's somebody you know and trust and they're really in a lot of pain and you want to give them a handful of Vicodin or something, 5 or 6 tablets, I think that's reasonable. But obviously we're being very careful with opioids at this point. All right, so tooth 3 is on the upper right. So right up, the first wisdom tooth on the upper right is number 1, goes all the way around to number 16, and then it goes down on the left side. The first wisdom tooth on the lower left is number 17, and then it goes all the way over to the 32. Children's teeth are actually lettered rather than numbered. But once one is an adult, this is how the 32 teeth are described. Now, Barry Tibbs finished his antibiotics. He's the guy that had the diverticulitis, and he's calling you and saying now he's having diarrhea. So you're worried that you gave him Augmentin and now he has C. diff, and so you have to ask him, well, what do you mean by diarrhea? How many times a day are you going? Is it totally liquid, or is it got some formed in it? Is it particularly odoriferous? As C. diff often has a very foul characteristic odor to it. Can you control your stools? Are you losing your stools? Are you having leakage? As C. diff often is associated with some leakage because of all the mucus. So what do you do? Well, usually we do the toxin test. So we send off a stool, they test it for C. diff toxin. There is another stool that just tests for regular C. diff, but you're going to get that 15% of the population that is colonized. So better off to do the toxin test. If the stools are formed, most labs won't even test them just because their feeling is that it's not worth doing antibiotics if someone still has formed stools. So treatment, vancomycin 125 orally 4 times a day. We used to think liquid was better than tablets or pills. We now know the pills dissolve and work very well. It stays in the GI tract very well. Fidaxomicin is probably the preferred, but unfortunately it's over $4,000. So very frequently you'll order the fidaxomicin. The patient will go to the pharmacy, not be able to afford it, and then they call you up and say, is there something better? And then you can actually use either the vancomycin, or if finances are a major factor and you really can't prescribe the others, Flagyl has a reasonable success rate. Martin Page. So Martin's 71 years old. Last A1C was 8.9. He's got a red third finger with a fluctuant area on the radial side. And so he has a paronychia. You can have a chronic paronychia or you can have an acute paronychia. The traditional treatment for this is to IND it. This is actually a felon. So if you have a lot of redness and inflammation in the distal tuft space there, sometimes you do need to get them seen by ID or somebody else, or at least get them started on a wicked strong antibiotic or C IV antibiotics, because you can end up with real problems if you have a felon that's inadequately treated. So again, if you've got a paronychia that doesn't look like it can be IND'd, you can go ahead and use some kind of soap and a topical antibiotic. Bacitracin is probably preferred to Neosporin just because of the incidence of neomycin allergy. About 15% of people or so are allergic to neomycin. So if you put it on it and it gets really red, is that a neomycin allergy or is that the infection getting worse? So if they've used triple antibiotic before and haven't had problems, they're probably not allergic. So if they want to just use that, that's fine. Mupirocin or Bactroban actually probably does have better penetration than any other topical antibiotic. If you're doing oral antibiotics, most people would use cephalexin. If you're worried about MRSA, you could use add Bactrim as well, or actually culture for the MRSA as well. And MRSA has a characteristic look to it. Most people that come in with MRSA come in and say that they feel like they've been bitten by a spider or they've had some kind of an insect bite. So it often has a very characteristic look. As you can see, this MRSA is the community-acquired strains. The 100 and 200 strains were just hospital-acquired, much more serious. The 300 and 400 strains are community-acquired and are usually sensitive to Bactrim, doxycycline, and sometimes the quinolones. And so you can see the Bactrim DS, remember you can even go 2 DS tablets twice a day if you've got somebody that is particularly infected. The doxy and as I say, sometimes fluoroquinolone, and we just talked about the various strains. All right, Philippe Rinaldi is an 8-year-old boy staying at a local camp. He's been swimming a lot, pain in his left ear. When you pull in the tragus, it hurts. The canal is red. There's a fair amount of pus, but you cannot see the drum. So the preferred drug is really the Ciprodex because Ciprodex can be used with a perforated drum, but many insurances don't want to pay for it because it's about 3 times more expensive than the cortisporin Odic. Now remember, cortisporin has neomycin in it, so unfortunately, again, you're going to have 15% of people that have allergy to it. So if it gets red and angry, then you have to decide what else to do. The only real PO treatment for otitis externa is usually Cipro. None of the other antibiotics usually work very well. So most of us will actually try to do Ciprodex at that point. If you have a mild otitis externa, you can actually use some acetosol. It's 2% white vinegar or 2% acetic acid. White vinegar is actually 5% acetic acid. So if you did half strength white vinegar, you're basically doing almost the same thing. And so some patients where cost is a major factor, that is an option. Again, my experience has been neomycin can be 10 to 15%. The literature really probably says it's probably closer to 3 or 4%, but either way, it definitely does occur. And as far as prevention, sometimes if you have somebody that's getting a lot of swimmer's ear, they can wear earplugs, but alternatively, they could also just put a little bit of 50-50 isopropyl and white vinegar in the ear right after they come out of swimming. So Millie Lynch. So Millie's the lady from the UTI symptoms, right? And most of us would go ahead and treat UTI if the urine supported it. The American Academy of Family Practice basically says you can treat it just based on symptoms. But now Millie's got a temp of 101, she's got nausea, she's got a really bad backache, and it does seem like her basic UTI has now progressed up into her kidneys, and she now has pyelonephritis. So pyelo is basically the same thing as a complicated UTI. If somebody's, got comorbidities or they're really sick, they can be hospitalized. But since the quinolones have come along, we don't really hospitalize people that much for pyelo anymore. We usually just use aggressive treatment with Cipro or Levaquin as an outpatient. All right, and Marty's back after his paronychia, and his paronychia got better. But now he's got a area on his foot. And so here's the area on his foot. So technically that's a diabetic ulcer, and diabetic ulcers can be very hard to get better. Lots of times we'll send them to the wound center, and they often will debride them and be more aggressive. Either way, using something like Bactroban and a strong oral antibiotic, even just cephalexin to start is probably reasonable. But you do need to be diligent when someone has diabetes. So you could do cephalexin, you could do cephalexin and Bactrim if you were worried about MRSA coverage. If you wanted to go stronger, you could go Augmentin and Bactrim, or you could even do, Bactrim or Clinda or Levo. And so not all foot ulcers go to wound care, but low threshold for sending them to wound care. All right, Tanya's here with a vaginal discharge. Her discharge is white, frothy, and yeasty. She's tried over-the-counter Monistat, and it didn't work. Well, Candida albicans is the most common type of Candida that women get. Usually a single dose of fluconazole will take care of that. Alternatively, some people use a single dose and then repeat it in 3 days. If someone is diabetic, you can actually put them on 100 or 200 daily for 7 to 14 days. There are other types of Candida, though. There's Candida glabrata and Candida krusei. Glabrata will often respond to boric acid suppositories. Those can be gotten over the counter. They're usually fairly inexpensive. Interesting, krusei often doesn't respond to fluconazole, but it usually will respond to the intravaginal treatments. Candida auris is also another one that is of great interest. If that one gets in your bloodstream, that can be fatal, that can be very serious. But either way, we need to be diligent about these candidal infections. All right, Bella. Bella Blair is a 66-year-old woman. She's got a red hot leg. She's not diabetic. And so cellulitis has about a 69% cure rate with just cephalexin. Goes up to 76% if you do Bactrim along with it. And if someone has a systemic infection, it's called erysipelas, and they usually have to be hospitalized. So very controversial of whether or not there's a role for steroids in cellulitis. A lot of people feel like steroids are just going to make an infection harder to treat. But if you have somebody on a good strong antibiotic, it does decrease the redness. There's some studies that were done around 2020. And the Infectious Disease Society of America considers it a weak recommendation only in non-diabetics. But in diabetics, of course, we would be even more cautious, and the role of steroids would be even more controversial. So Jimmy's had strep 3 times in the past year. He's 11 years old. Now he's got a 3-day history of fever, exudate in his throat. Both posterior and anterior lymph nodes are enlarged. No known cough, no known exposures. So anterior lymph nodes are definitely consistent with strep, but posterior lymph nodes are more likely to be associated with mono. So it's possible he has both. As many as 5 to 8% of people have both, but it's also possible that he just has good old-fashioned strep. So if you're suspicious that he has mono, he's 11 years old, he may be doing contact sports. I've never seen a ruptured spleen, but we still always warn if someone has mono that they shouldn't be doing aggressive contact sports. Usually if you put people on amoxicillin for for strep, and they have mono as well, they'll usually break out in a rash. It's a classic appearance. But if somebody has just strep, you can go with PenVK 500 twice a day is probably fine. You prescribe it 3 times a day, hoping they'll get in 2 sometimes. And the Amox 500 twice a day is fine. You can actually do, for kids, you can do Amox 500 mg per kg as either a once a day, twice a day, or 3 times a day dosing. With azithromycin, we used to do 12 mg per kg every day for 5 days, but now we actually usually do 12 mg per kg day 1 and then 6 mg per kg. So it's a little higher than the otitis media or other dosing with azithromycin. And usually there is a resistance rate of strep with azith, so we would usually restrict it to people that are penicillin allergic. All right, so this is the nightmare that causes me to suggest that EBV serology is best left to infectious disease specialists. The problem is sometimes people have EBNA and it's positive and it's interpreted as an acute infection. Well, that's one of the few things that it definitely doesn't show. Any of the others can be positive with an acute infection, or several of them can be negative. So basically the VCA IgM is the equivalent to a monospot. So if it is positive, it's helpful. Any of the other things, it's just extremely hard to interpret, I think. So buyer beware. So Jack Langtot, 70-year-old man with COPD. He's on Trelegy, which is a triple inhaler. It has a steroid as well as a beta agonist, as well as an LAMA or anticholinergic, whatever you want to call it. He saw his pulmonologist last week, and the pulmonologist said, yeah, you know, you're still not doing as well as I'd like you to. I'd like you to start taking azithromycin, 500 milligrams twice a week. And Jack's like, I don't know. They tell me not to go on antibiotics. Do you think it's a good idea? I trust you. And in fact, this is a common treatment now. Many times when people are not getting better, that's the next thing that they do. It does seem to decrease exacerbations and hospitalizations. Other options, theophylline oral is an option. I think we're going to start using that more now that fewer and fewer people will have insurance, if in fact the Affordable Care Act diminishes. Roflumilast is another PDE4 medicine. It's very effective, but can be very expensive. And low-dose oral steroids are another option. Again, disadvantages, thin bones, but most people, if it's 5 milligrams or less, feel like the risk is pretty minimal. The valved holding containers or spacers, the evidence seems to be that they improve things for people who have poor technique, but Dynamedics suggests that they really don't help if someone has good technique. So all these people that are pushing the spacers, unfortunately, the evidence does not seem to support any major changes unless somebody has poor technique. Azithromycin, this basically delineates the studies that have really supported doing it. As you can see, the benefits are relatively modest. It decreases hospitalizations by 1 a year and exacerbations by 1 a year, but that 1 a year can make a huge difference for some people. So, and Jack says, oh, while I'm here, one of my testicles is aching. You palpate his left scrotum. He's got a bag of worms. And his right testicle is very tender right over the epididymis. Now, the right hemiscrotum is about the size of the left, but a bit red on the surface. Left testicle is slightly larger and higher. I'm sorry, the right testicle is slightly higher than his left. So the right testicle is always higher than the left, right? The later and less complete descent of that right testicle. The bag of worms is most likely a varicocele, a varicose vein. If it's on the left side, we don't worry about it. If it's on both sides, we don't worry about it. If it's isolated to the right, it can indicate an intra-abdominal cancer. But that redness of his epididymis, the tenderness of the epididymis, would seem to suggest that he may have a mild epididymitis. We usually will treat that with antibiotics and get them better, but you could do an ultrasound and confirm that diagnosis. Epididymitis, if they're under 30, we treat them as if they've got a sexually transmitted infection. If they're over 30, we just put them on levofloxacin 500 daily times 10 days, and the vast majority of men will get better. If it is a man that has receptive anal intercourse, you might in fact want to do an injection of the um, medication plus a fluoroquinolone. But in the vast majority of cases, good old-fashioned levofloxacin will take care of it. Betty Sheldon's postpartum, and one of her breasts is red and painful. She's still breastfeeding only twice a day. That's the breast. It's not the whole breast. It's definitely red and inflamed, but not widespread. And the question is usually, can she continue to nurse? And generally, the feeling is on Diclox or cephalexin that it's fine to keep nursing, but that the choice is individualized. You want to palpate it, make sure that there's no sign of an abscess. Sometimes we even ultrasound. You can culture the milk to see, in fact, what it's growing. If you can't use Diclox or cephalexin, you can use Clinda. But as I've said many times before, it really worries me as far as C. diff. So, Lorraine Leeds. Lorraine's a 46-year-old woman. She walks a lot in the woods with her dog. She has no known tick bites, but she now has a fever of 101, malaise, severe headache, muscle aches, and maybe a bit of nausea. You do a blood count. Her white count is down. Her platelets are down. Her Lyme is negative. Now, Lyme is going to be pretty useless at this point if, in fact, she has Lyme, because it usually takes 30 days or so for it to turn positive. So she still could have Lyme, but Lyme doesn't usually cause the low white count and the low platelets. The one that does is the anaplasma. So anaplasma is the most likely cause here. Some people do tick panels. I haven't ever found them to be particularly helpful. I do find if someone's got classic symptoms, I'll go ahead and put them on doxycycline. Doxy gets people with anaplasma better within 24 to 48 hours, like 70, 80% better, dramatically better. The people who have Lyme, of course, you can leave them on it for the 10 to 14 days. Babesiosis is fairly rare in Maine. It does happen, but it is fairly rare. It does require a different antibiotic regimen. So those people will have low platelets and low white count as well. They'll feel real sick though. And so in this case, with this, you could make a case for doing a test for Babesia. But again, I'd probably put the patient on doxycycline and then only do testing for Babesia if they're not better in a couple of days. Anaplasmosis, as I say, doxy 100 BID times 10 to 14 days. It'll cover Lyme and Rocky Mountain spotted fever. There's more and more cases of Rocky Mountain spotted fever in dogs in Maine, but there still has not been any human cases reported that I'm aware of recently. State with the majority of cases of Rocky Mountain spotted fever, you'd expect it to be in the Rocky Mountains. It's not. It's more in the Appalachians, and so North Carolina, Oklahoma, Arkansas, Tennessee, and Missouri are the places that have the most Rocky Mountain spotted fever. Babesiosis, again, the preferred regimen is Zith plus atovaquone. You could use Clinda plus quinine as an alternative. And treat them for 7 to 10 days. The only patient I've ever had with babesiosis was so far into it that infectious disease didn't feel like she'd benefit from treatment. So Phyllis is an 83-year-old woman. She's getting married this Saturday. Today's Tuesday. She has a really bad case of laryngitis, and she was hoping for antibiotics or something so she could say her vows. In fact, almost all laryngitis is viral, so antibiotics are probably not going to be helpful. Systemic glucocorticoids have a limited role if you have somebody who really has a pressing need to use their voice. And maybe getting married is enough. So in this particular case, I put her on 3 days of prednisone. Her voice got better enough that she could get married, and she was happy about that. Billy Vale. Billy's 6 years old, bit by a tick 4 days ago. It looked like a small black-legged tick. Mom saved it. He has a bullseye rash. So the bullseye rash is pathognomonic of Lyme disease. It usually occurs sometime between 3 and 33 days after a tick bite. And Mom is like, well, can you do a blood test just to be sure? Well, we know that the Lyme test often won't turn positive for at least 30 days. So He has it, he should be treated. I guess the question is, what should he be treated with? Um, there is evidence that doxycycline is probably safer than we think. CDC says short courses are fine, but amoxicillin is also an alternative. We definitely want to get kids treated because they can get carditis, other serious complications. So we're going to go ahead and probably treat. There's a mg per kg thing for the doxycycline. I'm not going to tell you because you're going to look it up every time anyways, but I think that's probably what I would do with him. Oh, there it is, 4.4 mg per kg divided twice daily for 10 days. Amox, the original research was done with 3 times a day, so that's how we do it, and that's usually for 14 days. Cefuroxime can also be used. First generation cephalosporins are not considered an acceptable treatment for Lyme disease. All right, so Phyllis got through her wedding. We gave her the prednisone. She was able to say her vows. Now she has a painful vesicular rash on her side. It does seem to cross the midline. You'll often find that shingles comes just a little bit over from the small peripheral nerves, but the spinal nerve obviously does not cross the midline. And it is blistery, and it does look classically like shingles. So treatment for shingles, Valtrex, 1,000 milligrams 3 times a day for 7 days is what I do, just because that's all I can remember. But you could also do famciclovir or acyclovir. The acyclovir is 5 times a day, so it makes it a little harder. But it is on the Walmart $4 list, so you often can get it for cheaper. Pain control for shingles, there is probably a role for prednisone, especially if they present early enough. I think there's a role for short-acting narcotics too, especially if they've got a lot of pain. Gabapentin and the postherpetic neuralgia type medicines will decrease the amount of pain, but they usually don't get it to the point where patients are actually comfortable. Patches are approved for postherpetic neuralgia, and in fact, for most insurances, that's about the only thing they'll pay for them for. They usually won't pay for them for back pain. The prescription ones are 5% lidocaine. The over-the-counter ones are 4% lidocaine. But the prescription ones can be $200 a box, and the non-prescription ones are usually still fairly expensive, but nowhere near that. All right, so this is the article that's the only article I've ever been able to find that talks about gabapentin's benefit as far as shingles. And you can see that the amount of pain goes down from, on a 100-point scale, goes down to about 70 something. So that means their pain instead of a 10 is a 7. Well, that's useful. Is that really what you're looking for pain control, though? Probably not. So if somebody's still having a fair amount of pain, especially if you know them and they're your primary patient, using some short-term narcotics are probably a good way to make friends. All right, Jackson. Jackson's 7 months old. He's Betty's son. She had the mastitis. He's got white spots in his mouth. And Betty says, I think he got thrush. And so he does look like he has thrush. You want to take a tongue blade and see if you can scrape it off. If it scrapes off, it's probably just milk. If it doesn't scrape off and it looks really red and irritated underneath, it's probably thrush. This is a algorithm, and usually nystatin is what we've always used. In class, we did talk about using fluconazole, and apparently fluconazole is as effective and maybe more effective. Not something that I've particularly done, but definitely something that several of the students had seen done. All right, Isaac Bayes, not immunized. He's 4 years old. He's got a dry, hacky cough that he's had for 3 weeks. He's also got a 9-month-old sister at home who's not immunized. So if he's not immunized, what's a dry, hacky cough? Well, walking pneumonia can do that, but also pertussis can do that, right? Who whoops? Well, the classic person who whoops with pertussis is a kid that's, say, 18 months to about 3 or 4. So he might be whooping, and with whooping, it's cough, 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 big inspiration that sounds like a hoop, and that's where the whooping cough name comes from. The problem, of course, is that he's probably going to tolerate having pertussis, but his problem is that his 9-month-old sister, if she gets pertussis, there's about a 1 to 1.5% mortality rate, and about a 15% hospitalization rate. So normally we'll put them on prophylaxis, usually azithromycin, so definitely something you want to be thinking about. To diagnose pertussis, to really know whether it is, you have to do a nasopharyngeal swab, so that goes way up in. Treatment is azithromycin. It makes them less infectious and helps with the cough. Unfortunately, as we say, the mortality rate is higher than we'd like it to be. Pecte Sock, he went to spend a year with his grandparents. Now he's having 3 loose stools a day. He's having some fecal urgency and some nausea. Traveler's diarrhea, we try not to treat it if we can avoid it, because sometimes we'll make things go carriage. Believe it or not, C. diff is the same kind of thing. If they're fighting it off on their own, you try to let them. But if they have severe traveler's diarrhea, usually just a single dose of azithromycin, 500 milligrams, 2 tablets times 1, or 500 a day for 3 days. So you could do the Zithromax tri-pack. Campylobacter is not covered Campylobacter is a common organism and is covered by the azithromycin. It's not usually covered by the Cipro, which is what we'll often use empirically for diarrhea that's not traveler's diarrhea. And Don Jackman might be an example of that. He went out north fishing. Now he has 3 loose stools a day. Stools are floating and he has some nausea. Well, we could treat him empirically if he's having more than 6 stools a day, but if he has Giardia, he's not going to respond to it. And so Giardia is a parasite. You can actually do a specific stool test that looks for Giardia. We used to do stools for ovarian parasites. It's really not an efficient way to find Giardia now, and I think Sarah would agree that stools for O&P probably are of pretty limited value. So once somebody is felt to have Giardia, you definitely should probably get a Giardia test, and you can actually get a good sense from the test. Usual treatment is, most people use Flagyl, 250 milligrams 3 times a day for 5 to 7 days, just because it is so cheap. There are other anti-parasitic medicines, tinidazole and nitazoxanide, that can be used, but those can get pricey. So most of us will use Flagyl, and then if it fails, then go to one of the others. Many of the folks that have Giardia will also have a lactose intolerance for several months after, which is very interesting, I think. Don says he's seen things that look like spaghetti in his stools, and those are roundworms. That's what roundworms look like. It's just little pieces of spaghetti in the stool. Albendazole or mebendazole tend to be good treatments. They'll also treat the Giardia, and so since he has both, you could just use the one treatment. Anybody with high eosinophils, you also wonder if they have an enteric infection. High eosinophils, we always say it's worms and wheezes and weird diseases. So if they have worms, their eos will go up. Wheezes or allergies, they'll go up. And then there's some other weird diseases that'll cause elevation of eosinophils. Okay, Rebecca's here for acne. Not necessarily something you think of as an infectious process, but it usually is because there's certain bacteria on the face. If it's bad, if it's cystic acne, it's fine to go right to oral antibiotics. Most of us will use doxycycline, maybe 100 once a day. If it's really bad, often they'll ask for a referral to dermatology. Unfortunately, dermatology is going to tell them it's going to take 3 to 6 months to get better. And so I'm not sure that there's any great advantage. I usually start them on a cleansing regime and some topical antibiotics, or a topical retinoid. Differin is now over the counter. But if they insist on going to dermatology, and it's severe, Accutane may be an option. Accutane, unfortunately, they can't get pregnant, or she can't get pregnant while she's on it. And it is something that you have to be very careful with. It's a somewhat dangerous medication. All right, Tanya says her yeast infection's better, but now she has a grayish discharge that's fishy smelling. So that would probably be classic bacterial vaginosis. Treatment of BV, you can use Flagyl. We used to use single dose, but we don't anymore. Whether you have to avoid alcohol when you're on Flagyl, it's probably a myth. There may be an occasional person that has some sensitivity, but it's very rare. So, I tell people if you want to try a drink, go ahead, but if you get nauseated, back off. And you can use metronidazole gel, you can use Clinda. Don't use condoms if you're using the clindamycin cream. There's also oral clindamycin, but again, we worry about C. diff. And tinidazole is sometimes used with BV, although I've never seen it done. All right, Jack's back. His epididymitis is gone. His breathing's good. His toenails are really a pain, though. They're thick, they're really hard to cut, and they're discolored. He'd like to get them back to normal. And so treatment options, most people are going to do the terbinafine 250 PO daily for 12 weeks. There's topical treatments. Jublia is about 30% effective topically. VapoRub is about 30% topically, much cheaper than Jublia. Onychomycosis treatment with terbinafine is only about 60% effective, though. Although my experience has been that they get substantially better either way, and you can always repeat the treatment a few months later. So that's where we end up with most people. All right, Gary. Gary is a 32-year-old man. He's got a really bad sore throat. His rapid strep is negative, but you can see that his anterior pillars are pushed forward. He's got big tonsils. This is not what a peritonsillar abscess looks like. You can see that the uvula is midline. A lot of people think it's going to block off the airway, but in fact, there's a lot of airway in front of those tonsils. So tonsillitis like this, treatment, some people will go ahead and do oral antibiotics, assuming that they might have group C strep instead of group A strep. Some people use steroids, prednisone, single dose of dexamethasone, and keep an eye on it and let them know that they'll probably get better. Peritonsillar abscess, your uvula is going to be displaced. You're going to have total loss of that anterior pillar. See the pillar in front of the tonsil back there, you're going to lose that. And they have kind of a classic look. If there's pus there, it should be drained same day. Some people, if it's mild, will put them on Augmentin and prednisone for a day and then check them in 24 hours. But that's somewhat risky to do. I would encourage you to be very cautious with doing that. All right, Patrick is 6 months old. He's 8 kilograms. He had an ear infection 3 weeks ago. It was treated with a Mox 250 BID for 10 days. So normally for a child, 6 months old, we're going all to high dose amoxicillin. So that would be 80 to 90 mg per kg. So 80 would be 640 a day, 90 would be 720 a day. So he was 250 twice a day. That's probably not enough. And so you could actually go and then retreat him with high dose. Some people would go right to Augmentin. That's not wrong either. Some people would use Ceftonir. That's not wrong either. But I think that making sure that you use high enough dose at the beginning is worth thinking about. Interestingly, in England, they don't usually treat otitis media with antibiotics unless they're febrile and unless they're fairly sick. Most kids will be able to fight them off on their own. But here in the United States, we had an incidence of mastoiditis and meningitis back in the 1960s, so a lot of us are still pretty gun shy of not treating otitis media. All right, and that's all I got. Got it in under an hour, so good luck and thanks for playing.